So Manitosh, please introduce yourself.
My name is Manitosh Ghildiyal, and I am a community champion and a person living with HIV and also a TB survivor. So when we talk about TB cannot be talked alone, as HIV and TB are a co-infection which comes together. If someone is HIV positive, generally it has been asked to go for the TB test, and if someone comes TB positive, so he has to go for the HIV. So if even if there is the new technology came, but still if we talk about in the immunocompromised people, like people living with HIV, diabetes, is still the diagnostic of tuberculosis is the still a big issue, big challenge. So if we talk about the someone who comes newly positive with HIV, and they have to go to the multiple tests for the TB. So like even ultrasound and CBNet is there, and there are many tests like sputum test also. So but there are, WHO has recommended other tests like a urine based test called the TB-LAM test. So it is very easy through that to detect the tuberculosis, though still it is not available in India. So it is within the 25 minutes it is a urine based test, so anyone can get their result, and it will be like it is more effective than the CBNet test and other tests. Like it accuracy is about 70 to 80%. If we talk about the CBNet is only 40 to 50% in a pale HIV or immunocompromised people. So these all are the challenges.
Yeah. So, but still we are not able to find all TB, and we are finding more TB. We are finding more HIV. But number of people living with HIV who get TB is really alarming, and so we really need to find TB early and accurately. In people living with HIV and generally as well.
In general.
We have the tools. There is no excuse. So your insights.
We have a tools, and a community approach is very also important. Like they have program has identified the community champion as I'm also the HIV champion, community champion, TB community champions, and they are playing the very important role in this the bringing these new cases within the community, like key populations also. PLHIV, if we talk about the sex workers and transgenders, LGBT community people, MSMs and all. So the community champions are playing very important role in diagnostic, but still the technology is there, and but it can be this these tests can be provided in the doorstep of the people, but still it is not happening, and it's not happening. And if we talk about the other things like
Yeah, sure. So we need to screen people early, diagnose early, right?
Early diagnostic is very important, because if it becomes late, it can also cause the MDR and XDR TB. So the diagnostic plays a very important role.
And sorry to interrupt, and also the infection spreads, right?
Infection also spread, like it's become mandatory. So even if we talk about the immunocompromised people, it takes almost 2 to 3 months to diagnose tuberculosis. Their condition become worst day by day, like if you can imagine, like even when I got diagnosed, like my ART started first and ATT started later on, but it is like the vice versa, like ATT has to be initiated first and then ART. So because of that side effect, it become very difficult to manage the side effect, and TB medicines are so hard. So it's become very difficult to manage. So like person keeps on sweating for a month, you can imagine, with the fever, and they have to change clothes 3 to 4 times in a day, and they have to take the pills like paracetamol for the fever 4 times in a day. So these all are the challenges and the side effect management. You can imagine nausea, sweating and all is there, and You can see the depression. People also go on depression, like. So, and if we talk about the DR TB, interest-resistant TB,
So,
also.
sorry, how much was the gap between when you got diagnosed and when you put on treatment?
So it was almost 2 months. If we talk about the tuberculosis and HIV, also it took 1 month or more
you?
than for me.
Wow.
So because
2 months?
2 months. So they did my all mono test and they did the CT scan, this and X-ray also. So they did not able to identify like this. They are saying someone is saying like in the big hospitals like medical colleges, and they failed to identify. So that all was the challenge, and later on through the ultrasound they find one knot, 3 mm knot, and then they started my ATT. So still, if it was in year 2013. So if still in the situation is same, if when I was working in advanced HIV, it is advocacy project. So last year we went to the institute like AIMS, LNJP in Delhi, and the situation is still the same. So if someone come with the newly diagnosed HIV person come and is having all the symptoms of tuberculosis, but it has not been like there on the basis of the screening. Also, the doctor did not initiate the treatment. So I met with one guy. So his situation was also the same. And later on, it took almost 2.5 months to diagnose tuberculosis. So the person was on wheelchair, and he was taking the treatment from the LNJP. ART has been initiated there, but the person day by the condition of the person was becoming more critical. So they come to the AIMS ART to just cross check with the doctor with to take the second advice. So even the doctor said it's fine, he is not having the TB, but he was having the sweating and the weight loss, and the person was in wheelchair and fever too. So he unfortunately he was about to leave. That someone, when they came to know about the newly diagnosed people like with HIV, generally because of the discrimination and stigma, they don't generally prefer to talk with anyone. So I went running behind them like when they came out of the ART, because they feel like in ART talking with someone. So I tried to trace that guy and talk with him. So I realized this person is having the tuberculosis, and then we did the follow up, and finally the tuberculosis get diagnosed, and he is so healthy now. He is like after 6 months of the treatment, he become like fit. He is back to his work. So still we try to generate some evidence so that we can work for more advocacy work to bring the TB lamb in India. And it's still the same for the MDR. We talk about there is a shorter regimen, like MSF is also talking about the shorter regimen for it. In place of 18 months treatment, it can be done in 6 months. So it will be,
Did I hear you right? 18 months?
18 months.
DRTB treatment should be 6 months.
6 months.
That's available. That's possible.
It's possible.
But not available in
Not
India.
available.
In India.
Government is not rolling out.
And DR drug sensitive TB. The 6 month treatment should be 4 months, I think. The new one, which one? And latent TB should be 1 month. 146.
146.
But it's not available. Right?
It's not available, and it will be, if it comes out, like it will be very good for especially for the PHIV or immunocompromised people. Also because they are in 2 types of medication, like they have to take their ART also, and they have to deal with ATT too. So it become very difficult, and you can imagine like so much of pill burden. It can also be reduced. Thank you.
How were you diagnosed with TB? Sorry to take you back to that point.
It was through the ultrasound finally, and they find 3 mm node in my stomach, and then
Okay. And about the screening, especially among, for example, people living with HIV. I read in the Sankalak report, NACO, Sankalak. So that it's a verbal screening.
Yeah,
So,
verbal screening is
so,
also.
but WHO recommends use of like tools which are very effective in finding TB, even in lung TB, even in those without symptoms. So, for example, more than half yesterday, Dr. Sachdeva said about 60% of people were asymptomatic. But they were detected because of X-ray. So, should not we be using these tools to screen people who are more at risk of TB, who may have TB, and then offer them molecular tests, which is point of care, decentralized, take these services to the doorstep, because these are operated things. So, more insights.
So in earlier in the few programs of the national programs and some other programs also, there it was there, people used to go to the doorsteps and they collect the sputum also. So and then the microbiological test they do the sputum test, and then since the CBNet is there, so they recommend for the CBNet, especially for the pale HIV also. So this is the change, which happened, and we also advocated a lot for the CBNet, but still the machines are there, but it is one of the only the microbiological test is not there.
Yes.
So the CBNet is there, so still the stockout.
That is lab that requires semi-centralized lab.
Lab.
But now we have battery operated point of care decentralized ones like TrueNet. So
TrueNet.
which is both are WHO recommended and equally perform. So, but these can go further deeper into the community. So
it is very important to go, like even if talk about in some smaller villages, these facilities are not available, and so that is, if the technology is there, it can be taken, and it is battery operated only, so that it can be taken to the doorstep, and it will be very helpful in diagnostic of the tuberculosis.
And it is very important for us to remember that you were on a dharna outside the NACO for almost 49 days, 48 days?
43 days.
43 days. And I went there for several days too. But point is that the dharna was because of drug stockouts, right? And you people only finished the dharna when the drugs supply was resumed. So point is, you
resume in the sense
like
our people they have.
So when we know number of people who you tell the story, and then we also listen to you, that when we know the number of people who are on treatment, why is there a situation like drug stockouts, and this is very frequent. So over to you.
Yeah, if we talk about not only
first, tell us about the Delhi thing too.
Yeah, Delhi thing. Yeah.
What happened?
So it happened like it was a national stockout for the ARV drugs, especially DTG 50 mg, and which is given to the co-infected people.
So DTG is dolutegravir,
right? To the co-infected people, 50 mg to with HIV and TB co-infected people, then they have to take 50 mg separately with their medication. So there was a stockout of that medicine also, and I think second line ARV medicines also, and the pediatric medicines, or the nebracine syrup also, which is being given to prevent the newborn baby from the mother, the infected mother. So if we are talking about to end the HIV, so by 2030, so even though if many countries have eliminated the mother to child transmission, like Thailand, 2-3 more countries,
Sri Lanka, Maldives, so many other countries.
So other countries. If we talk about India, there will be such a huge stuck out, and they are the people who are they. When we talk with the NACO people, they say like it is available but very limited. Like if one person is registered in PPCT, so it is a one only. So if suddenly someone came positive with HIV as a pregnant woman in private, and she has been referred to the government facility for the nebrapine, so they will not going to give them. So it was the situation. Like I don't know, like how India is going to tackle with all this, and even with the TB thing and HIV also. It's the elimination is, I think we talk like still the far behind. So if there will be a stock out, so these challenges, still all these things will be the challenges, and these all are they know the numbers, as you said, and they were dealing the tendering thing, and the tender has been given to the blacklisted company. We heard that, and that all this causes a mess, big mess, and the people were left behind without no medicines, and they were struggling, and even they were not writing in their books so that people can advocate for it. There is no supply or like this. So it all happened, and we started even the capitals of India, Delhi, when it started happening in Delhi also. So we can assume like what was happening in all over the country. So then we from the Delhi network of positive people started these to go to we went to DSEX, and we have written many letters also to National AIDS Control Organization, and then finally we decided to go for this protest, day and night protest, because of we are not left with any options. So because people were dying, and you can assume like we cannot leave HIV medicine for ART for a single day. Even if we not get the medicines, even we cannot leave ATT for a single day. So how we are, even it can also cause a resistance to the medicine. It can be the big problem, not only for us and for government too.
Yes, absolutely, and moreover because essentially this is a human rights imperative, right?
Yeah,
it's a
human rights.
issue. There's no excuse not to
No excuse.
not to do it properly.
And as a community also we work, and we also pay the
Yes.
tax, and it is also our right to demand with the government. Absolutely.
Totally. Thanks a lot for putting it that way. So your message for World TB Day before we let you go back in the conference.
My message is very simple. I want to say, if the WHO recommended technologies and are there, and we should bring it to the national policies in India also, like diagnostic especially, and medicines also. The shorter regimen for the TB is there, so it has to be available in India also. So this is my message.
Sure.
Thank you.
Thank you so much. Thank you.